Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Our final speaker today is Dr. Dennis Fassbinder. Dr. Fassbinder directs the Computerized Dentistry Unit at the University of Michigan School of Dentistry. This unit is dedicated to research and education in CAD/CAM dental systems. His research interests and endeavors have been in the area of applied laboratory and clinical evaluation and the development of aesthetic materials and techniques that are specifically in the area of CAD/CAM dental dentistry. He sits in the editorial board of the International Journal of Computerized Dentistry and also serves as a reviewer for many other journals, including the Journal of American Dental Association, the Journal of Prosthodontics, Operative Dentistry Journal, and the Journal of Adhesive Dentistry. Today, Dr. Fassbinder will discuss the current evidence of clinical success and limitations with digital impressions in chairside CAD/CAM technology. Dennis?
I've been looking forward to doing this for quite some time. And I think it's important, if you don't already understand some of my bias, before I get into this, that I've obviously spent quite a bit of time working in this arena, and have spent quite a bit of time and effort with these companies as well, to the point that they have funded quite a bit of the research that I've done here over the years, as well as a number of educational programs that I've done. So keep in mind my bias. It's really simple. I like doing this. The question isn't, is it about liking to do it, though? We have these four systems primarily in the marketplace now that are driving this concept of digital treatment. And we've kind of arbitrarily divided them into digital impression systems by the iTero and Lava COS, and these chairside systems. But at their heart, they essentially do the same thing. Now, you've heard both Dan and Brian talk about the process and the value to their practice of the process. And when you talk to the representatives of these companies, they're going to sell it to you on the process. It's fast, efficient, quick, easy. I need powder, I don't need powder. But I'm going to suggest we need to look at them differently. We need to look at the outcome first. Think about how you purchase other things besides these pieces of equipment. Do you worry about how fast the car goes, or do you worry about what is the car itself? So I want to shift gears, and let's talk about the outcomes to let us decide, is it worth working in this process? Sometimes I think we get the cart before the horse talking about the process first. So what's the first process that we talk about? You got to record the image, the volumetric model of the tooth preparation or whatever's intraoral into the computer. That's a process. We're going to use some sort of a camera system. These are the four cameras of the systems. Okay? How big are they? How bulky are they? How easy are they to use? And many of the students here have obviously had some experience playing with these cameras. Okay, I've got to tell you, you folks pick it up a heck of a lot faster than most doctors in private practice because you don't really have the bad habits yet that we have to correct. But let's think about this process. What has to happen? Well, okay, you decide to do a couple crown preparations. And Brian really hit this hard about you really can't skip retraction and isolation. See, these cameras are line of sight cameras. They only record what they see. You can't see around a corner. You can't see into an undercut. You can't see under soft tissue. As much as we would love to have a camera that could see through blood, through saliva, under soft tissue, basically, why not just shoot it through the cheek? Why do they even have to open their mouth? I mean, that's what I would love to have, but it doesn't exist. So you have to invest in the basic concept of retraction and isolation. Is there anybody here who couldn't get an impression of that? No. The same holds true for this process of being able to record it. The question, though, is, okay, I record it, how accurate is it? Is there a difference between this stone process and this resin process? Are they equally accurate? You heard Brian talk about some things about all the risk. Yeah, okay, fine. But think about it. How many decades have we been doing conventional impressions and getting excellent quality restorations? We manage the process. But do we have to? Could we get the same outcome with a different, easier process? For example, if you try to explain to somebody the difference between how accurate stone models are and how accurate a digital image is, it's kind of self-evident. Once you get it recorded on the computer, it doesn't change in shape. There's no shrinkage. There's no worry about temperature. You've recorded a data file. It doesn't change. But is it equally accurate? Now you can go to the laboratory, and this is a very common project that people will do initially about fit. You'll make some sort of a typodont preparation, a master model. You'll replicate it a couple of dozen times. You'll make different techniques and make a restoration on that model, and then somehow measure it. In this case, they took a measuring microscope at the margin after the crowns were made and measured the fit at the margin. And you can look here, those are some well-fitting restorations, all of them sub 50 microns. Now, statistically, there's no difference in the fit whether you did it digitally or whether you did it conventionally. Now, that kind of flies in the face a little bit of what you've kind of heard, doesn't it? I mean, there's really no difference relative to the outcome. But in a laboratory environment, we can control that process very carefully. We don't have to worry about volumetric shape. Why? Because we take a graduated cylinder and a weight balance, and we're very careful in measuring out the powder and liquid, just like you do in the laboratories in the clinics, right? That's what those gram scales are for and those graduated cylinders. But obviously we don't do that all the time. So what else can we find out about how well these fit? Well, let's go into maybe more of a clinical situation to look in the fit. And this was a study done out of Boston, Dr. Kugel over at Tufts. They took 12 dentists in the Boston area who had never used the COS system and said, all right, tell you what, we're going to teach you how to use it. We want to put it in your practice. And then for the next 6 or 7 months, every time you do either a lava crown or a PFM crown, we want you to use the COS system and take a PVS impression of it. Do both. Send them both to the laboratory. Let the laboratory make you 2 crowns. We'll call 1A and 1B. We'll send them back to you. We're not going to tell you which one comes from which system. You try them both in, you decide which one's better, and you go ahead and submit the one you want, and then fill out this questionnaire as to why you did that. So they did this for about 7 months. 2/3 of the time, the doctor selected the digital crown. Whether it was PFM or whether it was a lava crown, didn't matter. So in a blind examination, a blind test, if you will, clinically, now there's no numbers on the fit like they were out of the laboratory, but you've got now different clinicians. You've got 12 clinicians' judgment saying, I would rather cement this crown. And we're going to take it from the point of view that they're probably choosing the better restoration. Now, why? Was it fit? Well, if you look at the questionnaires that they turned in, that's why they selected those crowns. And what's interesting about it is the top 4 or 5 all deal with fit, but not fit of the margin necessarily. How does proximal contacts become more accurate on a model? Do we somehow get a warped model out of a PVS impression that the proximal contacts move on us or something? One of the things that we overlook here is we work on stone models. What's the downside to stone? They abrade, they wear, they chip, they can be damaged in the handling. What's all the digital systems working with? Resin models. Much more resistant to wear. They don't shift, they don't move. If you took a PVS impression and you poured it out of a resin or an epoxy material, I'll bet you'd get a much closer result. Why don't we do that? Because that process is a pain. That process is expensive. It's not worth it for the adjustments we accept on a 1 or 2 tooth restoration. But there's no doubt digital was a better choice. Now, can we get some more data on how well those things fit? Is there a way to do that? Well, actually there is. Usually, you see some of these things on TV and they say, now don't do this at home. I want you to do this at home. This works, okay? In this case, this is a project that we just actually put the last crown in last week. It's a clinical project, randomized clinical trial. We're looking at 2 different ways of making zirconia crowns digitally. Now, the first 50 crowns we did in the project, 25 of each type, Dr. Navy and myself did that AB crown split. We took a PVS impression, we took a digital impression, sent them to the lab, sent them back to us. We didn't know which was which, tried them both in. But when we tried them in, what we did is we took a light body impression material and cemented the crown with that first. Now, the light body impression material will set up and generally stick to the inside of the crown. So what did we just record? The cement space. Now we lift that out of the mouth, we put in a heavy body impression material inside that, and we've replicated what? The die with the space between the crown and the prep recorded clinically. And now what we can do is take that with a blade and we can section it, and now we can actually measure margins, axial wall, and occlusal fit. So this is, potentially the same kind of quantifiable data we get out of the lab, but we're going to get it where? At the chair. And that's why I say you can do this in every crown you get back in the clinic. You want to see how well your restorations fit. And then you take it to the microscope and look at the difference there. In all areas we measured, digital impressions were more accurate than the PVS. And this is part of a controlled clinical environment. It wasn't that the crowns didn't fit. Okay, we very rarely ran across one that we wouldn't have cemented. But look at the difference quantitatively. And what's really interesting is I found a couple other papers that did the same thing. Look at how close their values are for the digital. 49, 48.6, we were at 51. Very consistent accuracy with the digital process. Now, if you think about it, it's got to be, right? Why do manufacturing companies move to assembly line type of processes? Because people get bored, and the quality goes down. And as we get bored and our mind wanders, things don't come out as well anymore. How does a computer get bored? It doesn't. It's built on the concept that you have repeated accuracy. So as long as what? The data going in is accurate, you should be able to get an accurate outcome. Now, another part of the process that you saw that Dr. Schroeder mentioned was, okay, we're going to scan the prep quadrant or arch, and then we're going to flip the camera upside down. We're going to scan the opposing. How do we put those together on the computer? So here we've got, on the Lava COS, the two arches have been scanned. How do we stick them together? Well, all of the systems do the same thing right now. You have the patient bite into centric, and you scan it from the buccal corridor. And then the computer takes that third scan and matches up the two models and aligns them. Now, I want to ask you, though, when you look at that, how do you get your lateral guidance? How do you program that cuspid-guided disclusion? How do you program that protrusive guidance? We can't. None of these systems will do that. And you heard Dr. Schroeder mention in those bigger cases, what did he do? He took the models that came on those plastic articulators and he cut them and put them on a semi-adjustable articulator. But how accurate is this, that process? Are we in the ballpark? Are we within a quarter of an inch? Are we within microns? Dr. Patinkin and I did this project. We developed this Typodont. And we took two very common clinical cases. One would be a distal extension case, no distal stop, lateral to the, or distal to the last prep. And the other was we did a single crown prep with a vertical stop distal to it. Generally, that's considered to be a little bit more predictable ability to get the vertical dimension correct. So then we took this Typodont, turned it into our master model on a semi-adjustable articulator, and then we scanned it a series of times with the COS and had the models made. Because really, I don't have to measure restorations with this. It's just another impression material. I just have to look at the models. And then we compared the vertical dimension on these models to our master model. How'd those come out? Well, on the quadrant side that had a distal stop, whether we scanned just the quadrant, similar to what you would do with a triple tray, or if we scanned the whole arch, we were about 1 to 2 microns off of the master model. So it was very accurate. So I'd have no doubt that if you had a single tooth prep with a distal stop, whether you scan the quadrant or scan the arch, you're going to reproduce that vertical dimension very accurately. On the other hand, when we looked at the distal extension side, it had a little bit more variation. The quadrant was off about 200 microns, and the full arch was off about 100 microns. Now, how do you put those two findings together? Either the models are accurate or it's not. Either the mounting accurate is not, but I've got two sides that kind of disagree. Now you got to look at the way the models are handled. It's that plastic articulator that has the flex. See, when you have a distal stop, so what if the articulator hinge flexes a little bit? You still have your vertical supported. On the other hand, if you have no distal stop and it's a distal extension case and that articulator has some flex, well, by all means, you're going to get a change in that vertical dimension. So what this take-home is, it's an accurate way to get it. However, the more preps you put in the arch, the more you need to move it off these plastic articulators. So it's not so much a process of the digital imaging, it's a process that they made a choice on the model. However, if you look at how the different companies have chosen to do their models, iTero has a significant advantage here because they have an aluminum articulator. See, both 3M and Sirona have gone with plastic ones, which have the degree of flex. So they're really more designed for, on those inexpensive articulators, single tooth type restorations, where the iTero one with the aluminum one has a better outcome. Now, truthfully, all the companies would like to get to a semi-adjustable articulator, and they're working on partnerships where they can begin to do that without having to separate the digital from the conventional. So let's look a little bit more about some of the chairside data, though, because that's pretty easy on the digital impressions, but now when I work at the chair, I'm not going to get the model. It's going to be on the screen, and that's all I get to work with. So how does that information compare? Do I still get similar accuracy? Because I'm going to have to draw that margin line the way Dr. Patikny showed in order to make the restoration. Is that accurate? Well, some people who look at this, they go, well, these are line of sight cameras, so you generally take them from an occlusal view, and you can't see around the corner, so how do you see what? The cervical half of the tooth. How do you see below the height of contour? Okay, so if I go below that red line, look at how flat it is. What teeth are flat down there? Those have been blocked out by the laboratory. And so that's what the camera does. It calculates part of the model because there was no data. It extrapolates, if you will. But we know that's not accurate. So some people will look at it and go, well, yeah, but see, that's not very accurate. How can we get an accurate restoration? Our model's not even accurate because that whole area was calculated. Fair statement. Fair comment. Now, you won't really have that on the prep, will you? Because the prep's going to draw. You shouldn't have an undercut in it. You should be able to see all the way down. But let's look at a stone impression. Is that all real data? Is there anything calculated in that model? I'm going to suggest that those three things probably aren't in the patient's mouth. So what's the difference here? It's not calculated versus actual. It's critical versus non-critical. I'm sure we've all pulled impressions out of the mouth that we've worked really hard to get a couple of crown preps in one area, and on the other side of the arch, you got a little void. And what do? That's not a problem. Okay? Because why? It's not critical to the success of the case. So the critical piece is the prep and what's going to influence that. Because we're building it on the computer, we're not going to have this vertical dimension issue on a model because we're not going to make a model. So we're going to get these types of color renditions to give us what? Surface intersection. See, what those colors are showing me is that the proposal for that restoration is somehow intersecting with the opposing dentition. Now, the red tells me that it's more than 100 microns into the opposing dentition, which obviously is going to be a, quote, a high spot. I'm going to have to take a diamond and cut that back. Now, nobody really wants to mill these out, put them in the mouth, and have them open a 1/4 of an inch, and they'll spend the next 45 minutes grinding them down. That's not the goal. Okay, we'd like to come closer. So will these colors get me there? Do I have that much confidence in them? Are they that accurate, or are they just window dressing? Yeah, they're in the ballpark, but you just basically got to wipe them out to get them to work. Well, Dr. Patikny and I did another study looking at that. We looked at the 4 colors to see the differences. You can see there's about a 50 micron difference in the colors as to what kind of intersection I'm going to get with the opposing model. And if you look over here, you can see if I set it at 0 microns or even minus 50, I can come almost within 10 microns of my starting point. Never making a model. Based on the pictures I took in the patient, designing the restoration, milling it out, putting it back on a master model, and measuring it, come within 10 microns. Is that accurate enough? I would suggest yes, because what? We're not getting lateral guidance recorded, right? So what are we going to have to adjust at the chair? Lateral guidance. Because we have no ability to record that radius from the hinge axis to the tooth we're working on. So as the mandible moves laterally, we're going to have to adjust that at the chair, just like you do with what? A triple tray closed mouth impression. No real difference there. So that's just part of the process that you got to think a little differently about, right? And that's what's difficult for us. You know, when we're faced new processes, we have to learn things, and all of a sudden, well, that's a learning curve. I mean, I think back when I went into the Air Force. I had to learn a lot when I put that uniform on. I got 2 weeks orientation. How to dress, how to cut my hair, how to button my shirt. I'm not kidding. How to put the name tag 1/4 of an inch above the pocket, perfectly horizontal. There's all kinds of things you had to learn. So I was in the Air Force for about 2 weeks. I was doing an AEGD program there. And I was in Wichita Falls, Texas. And about 2 months in, my residents, colleagues and myself, there's 4 of us, we had to go down to San Antonio to take this orthodontic short course. So we go down there. It was like what we called a temporary duty assignment. So we went down there for a week. So we get down there the first day. We're checking in. And they say, well, docs, you got to go over to finance to get your travel money. So if you want to get reimbursed for your travel, you got to go over there and collect it. So I said, okay, fine, where's that? So it was across the way. Now, what you have to understand about Wilford Hall, which is San Antonio, is that is kind of Mecca for training Air Force new enlistees. Almost all basic training goes on there. So you would go over towards these buildings and you'd see these huge paved areas, look at parking lots, with carports on them. Why? Because so many of the airmen had to stand in formation outside waiting their turn to go into the building, and the sun's so hot they had to protect them. Okay? So the four of us, there's four of us, and when you go into the Air Force as a dentist, you go in as a captain, so you're an officer. So we're walking over to accounting and finance, and we're strolling along, and all of a sudden we hear, tin hut. So reflex, we jump to attention. And we're standing there. And we're trying to look out peripherally. Okay, where's the general at? Somebody's got to be coming. What do we stand here attention for? We're standing there. We're standing there. Probably a half an hour goes by, probably actually more like 5 minutes. It felt like a half an hour. And his master sergeant, drill instructor, comes walking up to us. He snaps off, jumps to attention, snaps off a sharp salute. Said, sir, you're new to the Air Force, right? We said, yes. Why? This is for you. We're all standing there at attention, not knowing what we were supposed to be doing. See, it was a new process. It's pretty embarrassing. Here we had a couple hundred airmen standing out there waiting for us to do something. And we're out there looking sideways, who's coming, who's coming? Okay? See, it's part of the process. You've got to learn these processes. Now, truthfully, with a little bit of learning, it becomes pretty second nature after a while. But let's look at this outcome now. Isn't this one of the classic ones you hear about? How well does it fit? And this is, many of you had this perception, you know. I look up there and I'm thrilled with what I see. Because you don't appreciate that none of those were made in the last 10 years. Those were some of the earliest ones that we made. But yet most of the perception is that this type of dentistry, that's like an island of ceramic floating in a sea of resin. You know, the bonding will take care of it, it'll fix it. No. That's not the way the systems have to work. So what kind of numbers can I give you for this? Well, CEREC has fit very well ever since its introduction. And there's a lot of data out there, some of it generated here, some of it elsewhere, that shows that consistently in the evolution of this system, fit really hasn't been the problem. Now, what about some of the other ones? Well, this is E4Ds. Now, what you have to appreciate is CEREC was the leader in this environment. They were the ones who did all the initial work. So when you go and look for any kind of literature, it's going to be very, very skewed toward the Sirona CEREC point of view. For example, E4D's only been out for about 4 or 5 years. This is the only study you can find about fit. And if you look at the margins, they're pretty good. You know, they're pretty small, but look at the gap along the wall. A little bit thicker space there than we generally get with the CEREC system. Now, is that a problem of the process? Okay. I mean, that's a good question. And a lot of times people criticize me when I start talking about this. Well, you've been doing it for 20 years. I would expect yours to fit well. That's a fair statement. So that's why we did this study. What we did is we went to 7 dental schools and 1 VA clinic in Texas, and we asked them to give us a doctor who had not used the CEREC machine for more than 18 months, 2 years. They had to find a dental assistant who had never used it at all, and then find a dental lab that they worked with that was certified in making Empress restorations. And then we sent them 30 of those quadrants down and said, okay, we want the docs to make 10 crowns on that one prep and cement them. Then we sent a DVD for about an hour's worth of training for the dental assistant to learn how to take a picture and design a crown, mill it out. They made 10 crowns, the doctor cemented those, and then sent the other models to a laboratory and had a laboratory make them 10 Empress crowns, and the doctor cemented those. And then they sent all the models back to us at Michigan. And then Dub Subbo, one of our grad students years ago, sat down and we cut every one of the crowns open, and she measured them internally. So whose crowns fit the best? No difference. No difference in the fit. Yeah, the lab tech had trouble on the axial wall here, but they did better on the occlusal wall there. But marginally, there's no difference. Now, how can that be? If this is such a difficult thing to learn to do, and this is such a problem process to figure out, how can a dental assistant with 1 hour of training make the crown fit the same way? Now, there's an important part of this project I haven't told you about. Whose prep did they work on? That prep had been tested at least a dozen times to make sure it fit before we sent it. Because we weren't testing the data going in, we were testing the system. And that's the important piece here. It's the data going into the system that's important, These processes are predictable. They're just machines that have been fine-tuned to get the accuracy we're looking for. But those are easy things to measure, right? Those are laboratory things. Yeah, okay, great. That helps me a little bit, but I really want to know, how do they perform in the mouth? What is the outcome? Do I get success? Do they break? Do they fall out? How long do they last? These kinds of questions. And so obviously the only way we're going to get that kind of data is do what? Do clinical research. And so we've been fortunate here at Michigan to be involved with this for a long time and have done a lot of clinical research that I'll share with you now. And so one of the first areas we looked at were onlays. Okay, we weren't too interested in doing crowns because I don't know if they really alluded to it earlier, but when these systems were first invented, it wasn't because people were upset with the labs. They were developed because we wanted to do better chairside restorations. We're competing with amalgam, composite, and glass ionomer. We're not competing with laboratories. Now, as the systems have evolved, yeah, the laboratories are the ones who are getting the most interaction with them. So we'll take a look at this type of an onlay, and one of the things you have to appreciate when you go into this type of an area is we're going to maybe be doing a type of restoration you're not comfortable with. That's a preparation for a bonded ceramic onlay. Some of you may look at it and go, well, it's not going to stay. It's going to fall out. Well, if you have confidence in the bonding process, you're not worried that that's going to stay. So you have other dental issues you have to decide on besides just the fact, is this process going to work for me? Is this the kind of dentistry I want to do? Do I have confidence in doing these types of restorations for my patients? So what's one of the biggest issues people would be concerned about if you're moving into an adhesive ceramic type of a process? Post-op sensitivity. How much do my patients hurt? We don't want to have this ongoing problem to have to deal with. They're always coming back, oh, it hurts. It's sensitive to hot, it's sensitive to cold. What am I going to do? That's not going to help us in how we treat our patients. On the other hand, what is the post-op sensitivity? Now, Gordon Christensen has said that in an adhesive environment, generally 1 out of 3 restorations will be sensitive. Frankly, if I had that problem, I'd have quit a long time ago. I'm not going to deal with 1 out of 3 patients having post-op sensitivity. Now, this is generally what the chart will look like for our post-op sensitivity on some of our longer clinical projects. We'll get some 7, 8, 9% of our patients in the first couple of weeks have some sensitivity. We'll have to see them once, generally to adjust the occlusion. Keep in mind, if you miss the occlusion, lateral guidance isn't quite right, what's a patient going to do the first 3 to 5 days? They're going to grind on it. Tooth's going to get sensitive. You bring them in, adjust that lateral guidance, sensitivity goes away. Now look at how much sensitivity we have after that. 0. And if you look at the half dozen or so clinical projects we've had running lately, how much sensitivity do you see there? And what's unique about this is there's no 2 cements that are alike. There's no 2 ceramic blocks that are alike that are used in those projects. It's the same process. It's all done with the CEREC system in a 1-appointment procedure. But look at how little post-op sensitivity we have. So does the digital process cause this problem? Absolutely not. Now, I can suggest maybe why it doesn't. Can't prove this to you, but there's some advantages to doing it in 1 appointment. For example, you cannot make the image if you can't isolate the prep. So you have to do that up front. I'm convinced that many of us can get impressions of preparations we cannot isolate. We can push that impression material in places we can't keep dry. So we get the impression, it goes to the lab, they make us the ceramic, and what do? We temporize the case. And what happens to the patient if the temporary comes off, or maybe the temporary wasn't gray? The tissue gets what? Inflamed, it becomes hyperplastic, and how do we get it isolated? We don't. With these systems, you got to do that up front. So guess what? It precludes you from doing things you can't isolate. So that's one advantage. Number 2, you're restoring it the day you cut the prep. Think about the PROS literature about doing immediate dent and sealing when they cut the prep while they make the temporary, so for the following 2 weeks, the tooth does not become sensitive. We've just taken that 1 step further and said, no, we're going to restore it the day it's prepared. And I think those 2 things alone cut down this problem with post-op sensitivity with the digital application. We've done a couple other clinical projects with onlays. Here's one that we did a randomized clinical trial on 2 different ceramics with the CEREC system. They're both adhesive ceramics. One's a lucite reinforced, one is a feldspathic material. What I really like about that picture there is I get to cut 2 gold restorations out and do 2 porcelain ones instead. See, that's part of the perception, right? We have this perception that gold is an excellent restoration, and it is. But what's the problem many of us have with it right now? I don't have a problem with it. The cost is getting very high, yes, but many patients don't want to see that anymore. So what do dentists want? We want white gold. We want the advantages of gold, we just want it to be white. Well, is this material coming close that way? So part of what we looked at is we'd use these two different materials in an onlay situation. We put it in with what? A self-etching material. We're not doing some of the total etch processes that we were very comfortable with, knowing how long those would hold up. Now, one of the things we found as we begin to have these patients come back over time, especially the 3 to 5 year recalls, and if you look really carefully, and after standing in the back, I'm not sure you can be able to see this, but the margin of this restoration is right here. We kept the facial cusp. Look at how this margin has kind of started to open up, just kind of wear a little bit. Now, why would that be? Well, because the cement is the weak link between the ceramic material and the enamel. It's going to preferentially wear faster than those two materials. So if we start to look at something like this, and if this was the first time you saw this patient, you might think, boy, that restoration didn't fit very well. I mean, look at the gap there at that margin. Look at how it jumps. Now, granted, that's not the kind of occlusion I would like to have in my restoration. That's a working interference. But it still illustrates the point. Look at that gap. Look at how big that margin is. And I personally think for many years, this is why many dentists who saw these in their practice go, I'm not doing this kind of work. Look at how lousy they fit. Because this is what they would see. But what's nice about doing clinical research is I have the pictures from when we did it. So if you take a look at that place right there, and you look at it when it was tried in, and at 6 months, it wasn't there. That's evidence of what? Occlusal wear over time. Because you don't see it here. The similar margin right here also extended here. I don't see it here. Guess what? There's no lateral guidance across it. So we definitely have this occlusal stress on these restorations affecting the margin integrity over time. The question is this really a problem? Well, there's no caries that we found gets developed. Very, very little margin discoloration occurs. We don't get big surface chipping to occur either. So other than the fact that I could take an Explorer and find it there, or that my hygienist could find it there, is it a problem? I would suggest no. And actually what it brings up to my mind is maybe we should be doing maintenance. Because think about it. What if I took an air abrasion system, just clean that margin out, resealed it with a flowable composite? Wouldn't I go back to zero? The restoration's fine. We don't usually think about it that way as a restorative person, though. But look at some of the models here. Here they are at baseline, 2 years, 5 years. Look at how the margin has become more evident. Another one, baseline, 2 years, 5 years. Now, why those time periods? Because some nice work done many years ago in Alabama and North Carolina showed that that margin kind of reached a level of stabilization. About the vertical dimension would equal about half of that gap. So if I've got about a 75 micron gap, I'm going to get about 40 micron loss vertically of resin cement there, and then it tends to stabilize. So if you look at our chart on margin integrity over time on these projects, yeah, it starts to drop initially, but then when you get about 2 to 3 years, it kind of goes flat. It's not a forever process because there's a limit to how far the stress can affect that resin cement. But given the choice, and if we ever decided to do this, we could do an add-on to these projects to bring in some of the 6, 7, 8-year-old restorations, try to remarginate them and see what happens to them. Because otherwise, there's not a whole lot of change that occurs to these restorations over time. We're not seeing a great deal of fracture, chipping, debonding, or anything of that nature. You will see some of the margin wear over time. And yes, these are monochromatic blocks, one color. They're not stained and glazed or polished. But that's the kind of match that you can get once you get a feel for how the ceramics work. So on this particular project, the end of 3 years, we don't have a whole lot to report about. So it's kind of a boring outcome at times. We're looking for smaller changes that would be predictive of long-time success. And basically what we're finding out is the biggest predictor that we're seeing is this margin wear. We can track that over time. We can see that it increases over time, but it doesn't seem to be detrimental to the longevity of the restoration, especially if you start to look at using crowns. See, a lot of people are more interested, well, how do these do in crowns? Thinking that it's a bigger restoration, it will show us more failures because there's more of it. And actually what we're seeing is just the reverse. The more occlusal margin you have with these restorations, the more stress that can occur on the margin, the more change you will see. Because really, how much stress occurs on the buccal or lingual of a crown margin? We hope there's stress if they pick up a toothbrush. Maybe if we're lucky, floss. But other than that, what's really wearing that resin cement out of there? We don't really have any kind of stress. So on a crown situation, unless it breaks in pieces or a part chips off, these are pretty easy projects to track over time without a lot of change. And here's a good example of one. This is the Emax material that Dr. Patikny alluded to. It was not developed to be done as a chairside restorative material. It was developed to be a more translucent coping to compete with zirconia, because zirconia was first launched was kind of opaque. And so they wanted something a little more translucent, had good strength. But then doctors who had this CEREC system or the E4D system go, well, shoot, I want a stronger crown. Could I make it in an entire monolithic restoration? And you can. So that was the basis of this project. We started out with 62 full contour crowns, and then we added another 38 partway through using a different cement. And actually, that's the big outcome in this project, because typical full crown preparation, okay, it's a ceramic crown, so same type of a preparation we do for any other ceramic. And the reason I put that case in there is because of all the variety of colors in this tooth. Now, very often, doctors don't want to become laboratory technicians to learn this concept. You know, we're not in it to get into layering porcelains and put in cutbacks and these kinds of things. We want to be something pretty straightforward and easy. But with this material, you have to fire it in an oven in order to cement it, because the block is blue. So when you mill it out initially, you get these blue blocks, blue crowns. Now, you can't cement these because they're not fully crystallized at this point. You have to put them in the porcelain oven. You have to crystallize them. It takes about 20 minutes. And so when you do that, you have the opportunity, if you want, to do a little staining and glazing. Pretty simple process. And then when you fire it, it goes through the crystallization process, goes from 40% crystallized to 70% crystallized, and it gets the color change. And now that's the type of restoration that you would be cementing. Now, the reason I showed you this one is because the cement had a bigger outcome than the material. Look at how dark these got within 6 months to a year. Now, is that a problem with the process? Is that a problem with the ceramic? Or is it a problem with the cement? See, this was an experimental cement. Okay, it was a self-etching, self-adhesive cement, which we know doesn't tend to have the best bond to the tooth. And when these crowns actually debonded, which they did at about 24 months, all the stain that you see was between the cement and the tooth. There was very little bond. What was holding them in was just the mechanical preparation of the crown prep. But if you look at these over time, here's this one delivered. And yeah, I got a little fancy, put a little color in the grooves. Okay, they look better on the photographs that way because they get a little depth. But really, there's just one color on this facial. The white cusp you see is the block. That was the color of the block. That cervical color was the only color put on the surface of the crown. And look at it over 4 years. It's held up very, very well over time. So in this project, which Ivoclar loves very much, because we didn't really find anything other than this experimental cement didn't do what we would expect a cement to do in these types of restorations. Because you don't want your restoration to fail because the cement is not bonding to the tooth and is causing the leakage that gives that kind of a dark gray color to it. So when you look at the onlays, that's really where more of the stress is. That's where we see more of the changes, as compared to the crowns, which really don't have a lot of stress on them. And really what was interesting about this project is it was a material that wasn't designed for chairside use. You had to invest in a porcelain oven to use it, and yet it's probably one of the most popular materials that chairside dentists use for their full crown applications right now. So even though you might think, well, doctors really don't want to become lab techs, they don't. Who does? The dental assistants. That's who does most of the staining and glazing in private practices, not the doctors. Now, these are the catastrophic failures we're worried about, right? When you talk about, well, I don't really want to do these on second molars. I even saw Dr. Schroeder, he put cast gold on the molars. All right? All that does is negate some of the risk, because you can use these in other places as well, too. But how do we avoid these? Is this what happens 20% of the time with these types of restorations? Does digital compromise it because they mill it and damage the material? Is the materials we use kind of on the weaker side? They don't really have the strength of a zirconia, so maybe they won't last as long. And so it's a common issue that, well, I like it, I see what you're talking about, yeah, I probably can learn, but I just don't like doing porcelain in second molars or first molars. Okay, but look at the success we've had doing it. Those are our clinical projects here at Michigan. A variety of ceramic materials, a variety of cements. And our outcomes are not unique in this environment. Look at some of the other ones. And what's really interesting about this digital environment, especially in the CEREC area, look at the length of these clinical projects. Why did we have to do that? Well, because, as Dr. Bain alluded to, you had to prove the concept worked. Because when it was first launched, most people go, oh, there's no way this is going to work. Well, as it turns out, there's more and more clinical research to show actually it is a very predictable outcome and is at least on par with anything we get from the dental laboratory. So it does come back more to a choice of process. Now I want to read this to you. Scientists from the RAND Corporation have created this model to illustrate how a home computer could look like in the year 2004. Now look at the date, 1954. However, the needed technology will not be economically feasible for the average home. Also, the scientists readily admit that the computer will require not yet invented technology to actually work. But 50 years from now, scientific progress is expected to solve those problems. Now, you know what I'm really bummed about? I didn't get a steering wheel on my laptop. Okay, now, yeah, it's funny, it's interesting, but think about it. Some people sat down in a room and thought this would be of value to us down the road. Aren't you all willing to give up a room in your house to have a computer? So what do you think they heard when they first talked about this? Okay, how about this? This is closer to home. Who was the bright person who had the idea to put a hockey arena in a football stadium? I mean, what made somebody think that was a viable thing for us? And then what month did they pick to put it? December. We have a lot of snow and freezing weather in December, don't we? Now, why did they pick end of January, first part of February? No, we picked that. Now, for those of you who went, you knew it was a raging success, right? Okay. The attendance of that game actually set an NCAA record, not just for hockey, but for all athletic sponsored events by the NCAA. Now, since then, it's only been broken by one game, right? Everybody here should know it, right? It was the game under the lights against Notre Dame. They put 113,800 and some people in the stadium. Okay, but now think about the people who came up with those ideas. You think those are different? Think those are processes you have to think about getting better at or changing the way you think about it? Think about the process to put that thing in the stadium. Now, I've been fortunate to spend time with you here this afternoon to talk a lot about the work we've done, but obviously, I've had a great opportunity to work with some really talented colleagues. And it's a rare opportunity to get to stand in front of the school and thank them for that, and I definitely want to do that. I've also had a great opportunity with some of our AHD residents to do some projects, and hopefully with maybe some of you students as well. And it's also a rare opportunity when you get to thank one of your mentors in public. Now, I've been the recipient of a lot of effort because of this system. I just happened to get here in '91 after I came out of the Air Force. Remember, I had to learn to do that. Well, I had to learn also to be a faculty member here, too. And I remember when I first got here, Dr. Dennison, who I think is here somewhere, where is he? He said he was going to be here. Don't let him hide. Where's he at? There he is, right here, okay? You can blame it all on him. He was the one who identified this as an area, as a restorative group, we should look at. There's something interesting here. There's materials, there's preparations, there's a lot of innovation. We could really do some neat things with it. Now, coming out of the Air Force, I had no background in clinical research at all. I knew how to treat patients. I was doing that all day long. And so I would like to thank him publicly as being one of my mentors to really help me learn the value of doing this kind of work. Because as you can see in the digital area, I mean, I purposely picked Dr. Patikny and Schroeder because of that's what's driving a lot of the digital pieces. It's private practice driven. It's process driven. And only by doing the evidence piece that you have the outcomes to balance that out can you really make a good decision. Is this something of value in how we treat our patients? Now, I want to leave you with one last thing. Many of you will look at that and think that's a sunset. Actually, it's not. There's quite a process I had to go through to see that, because you're going to look at the sun rise above the clouds. These are the clouds here. Come on. Of course, I had to go to 9,700 feet to see it. So think about that. Sometimes going through the process is an ordeal, is a challenge, just like school is. But there are some very nice outcomes that occur that make the process worth going through. So thank you very much for your attention. I'll turn it back over to Dr. Fitzgerald again.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.